Hello, and thank you for joining the Pituitary Network Association's webinar program, which is brought to you through the support of our sponsors and our expert contributors. The PNA is dedicated to educating people with pituitary disorders, their families, and their healthcare providers. The PNA is a nonprofit organization that relies on the support from our members and donors. During the webinar, feel free to type in your questions at any time, but please note that all questions will be saved until the end of the webinar. We have allotted time to answer as many questions as possible. Any questions that are not answered will be reserved and answered by email. Today's webinar, Cushing's Disease, Recent Advances in Medical Therapy, is being presented by Dr. Eliza Geer. Dr. Geer is an endocrinologist who specializes in caring for people with pituitary and neuroendocrine diseases. She is the medical director of Memorial Sloan Kettering's Multidisciplinary Pituitary and Skull-Based Tumor Center, located at Memorial Hospital in Manhattan. Their multidisciplinary pituitary team provides personalized surgical and medical treatment for people with pituitary and skull-based tumors, including prolactinomas, growth hormone secreting adenomas, acromegaly, and Cushing's disease. Their overall goal is to improve and advance the care of people with these conditions. Dr. Geer's research interests focus on achieving a better understanding of how and why pituitary tumors develop and characterizing long-term outcomes in patients with Cushing's disease. She has conducted a number of studies investigating body composition, adipose tissue regulation, and appetite in patients with Cushing's disease, and she is involved in clinical trials investigating new medical therapies for patients with Cushing's and acromegaly. Dr. Geer completed her internship and residency at the New York Presbyterian Hospital, Columbia Medical Center. She was a fellow in endocrinology and metabolism at the Icahn School of Medicine, Mount Sinai Medical Center, after which she was a member of the faculty for 10 years. She is currently an associate professor of medicine and an active member of the Endocrine Society, the Pituitary Society, the Pituitary Network Association, and the American Association of Clinical Endocrinologists. Dr. Geer, thank you so much for your involvement with the PNA's webinar program. There's going to be a brief delay as we change presenters. Dr. Geer, you should see on your end a note to accept. I can see your screen.
Great. So can everyone hear me?
I can hear you, yes. Okay.
Great. So I want to thank you, Tammy, and the Pituitary Network Association for inviting me to speak. I want to thank everyone who's joining today to hear this talk. It's a real honor for me to talk to people who have experienced or are experiencing Cushing's. You know more about this topic than anyone else, so I value your input, and I look forward to hearing your comments and questions at the end. Showing some disclosures. So we are involved in a number of clinical trials looking at new therapies for Cushing's. And my institution, Sloan Kettering, has received support from the sponsors listed here for our participation. I've done occasional consulting work for the companies listed, and I'll also be discussing some off-label medical therapies. So I'm going to first go through a brief overview of Cushing's disease management, and then I'm going to talk about currently used medical therapies, including tumor-directed therapies, adrenal-directed therapies, and a cortisol receptor blocker. I'm going to be discussing combination therapy for people who have severe disease and therapy for aggressive tumors. And at the end, I will discuss new therapies that are in clinical trials. So I'm showing here the treatment algorithm for Cushing's disease. After we've established a diagnosis, pituitary surgery is first-line therapy. We sometimes consider medical therapy if there's severe Cushing's and there's unstable disease that we need to stabilize immediately, or if there's a delay with obtaining surgery. After surgery, if there's remission, then we just continue to monitor over time. I tell my patients I want to know them forever, so I recommend at least screening once a year to make sure you're in continued remission. If there's recurrent or persistent disease after surgery, we often recommend a second surgery. At that point, if there's still persistent disease, then we have some other options listed here. We have radiation therapy, which is decided on sort of on an individualized basis. But if we do decide to move forward with that, it can take a few years to take effect. So often we will almost always need medical therapy while waiting for the radiation to take effect. We have our medical therapy options, which I'll be discussing today. And we have the option for bilateral adrenalectomy or removing both adrenal glands. So there's a real need for medical therapy for Cushing's. I'm listing some of the indications here. As I mentioned, we need medications if there's a life-threatening complication. We often use medicines in some settings prior to surgery. If the tumor is in an unfavorable location for surgery, we'll need medical therapy. So what do I mean by that? So if the tumor is extending outside of the pituitary into areas near the pituitary. This is very important real estate where the pituitary is located. And on either side, there's the cavernous sinus, which has a large artery, the carotid artery, which goes up to the brain, and some cranial nerves that are involved in eye movement. So this is not a favorable place to operate. It increases the risk of surgery substantially. So if we have a tumor that's involving these areas, then we may want to consider debulking the portion that can be removed and then treating with medicine after that. So surgery is an excellent option for most patients and often is very successful, but it's not successful 100% of the time. So with a small tumor, a microadenoma, tumor less than a centimeter, surgery is typically successful in anywhere from 65 to 90% of the time with an expert surgeon. For large tumors, it's a little harder to achieve a surgical remission, so we tend to see this in about 65% of the cases, or sometimes less. And unfortunately, we don't know why this happens, but recurrence rates are relatively high with Cushing's. We tend to see late recurrences, so I've seen patients who've been in remission doing great for 10, 15, even 20 years that can come in with a recurrence. So that's why, as I said earlier, we want to always monitor over time and screen once a year for recurrence. But if a recurrence does happen, then we will consider surgery again, but we will also consider medical therapy. After the second surgery, success rates are a little lower, so anywhere from 20 to 60%, obviously depending on a lot of factors, including tumor size and location. And as I mentioned, if we decide on moving forward with radiation therapy, one of the downsides is that it can take a number of years to take effect. So during this time, we need to treat with medical therapy. Again, bilateral adrenalectomy or removing both adrenal glands can be an excellent option for some people. It basically cures you of your Cushing's almost 100% of the time. It's getting rid of the source of the cortisol. However, it doesn't get rid of the pituitary tumor. So one of the risks associated with this can be a progression or growth of the pituitary tumor over time. In the past, this was called Nelson syndrome, which kind of refers to a very dramatic, increase in size of the tumor. We tend not to see this sort of dramatic change in tumor size as much because we monitor people very carefully. So after adrenalectomy, we're checking ACTH levels, we're doing MRI scans to check the tumor, and if there's any change in size, we can then address that with either more surgery or radiation, but this is a concern and one of the downsides of having a bilateral adrenalectomy. So now I'm going to talk about currently used medical therapies, including tumor-directed therapies, adrenal-directed therapies, and our cortisol receptor blocker. So this figure shows the potential targets for treating Cushing's. We have medical therapies that work at the level of the pituitary tumor, shown here. We have Pasireotide, which is a somatostatin analog, which I will be discussing, and Cabergoline, which is a dopamine agonist. We have medical therapies that work at the adrenal gland to reduce cortisol production. And then we have a medicine, mifepristone, which blocks the cortisol receptor and which is located throughout the body. So I'm going to talk first about tumor-directed therapies. So starting with Cabergoline. So Cabergoline is a medicine that's been around for a long time. You may be familiar with it. It's first-line therapy for prolactin tumors and very effective for these tumors. But we also use it for ACTH tumors. tumors that cause Cushing's, as well as growth hormone tumors. There have been no systematic large trials looking at this medicine in Cushing's disease, but we have a number of small studies. Some are shown here. These are a list of kind of small studies looking at this medicine. This column shows the number of patients included in each study, and you can see the largest one was 30 patients. A range of doses were given. We tend to use higher doses of Cabergoline in Cushing's than we do for prolactinoma patients, for example, sometimes up to 1 milligram or 2 pills daily. And this study, most of these studies, and most of the studies I'll be discussing, use 24-hour urinary-free cortisol to assess response. We know that there are a number of measures that we use to both diagnose Cushing's and to establish remission, including the 24-hour urinary-free cortisol, as well as the midnight salivary cortisol, which looks at, the circadian rhythm or the daily rhythm of cortisol, and the dexamethasone suppression test, which looks at autonomy, or how does the cortisol respond to external, synthetic cortisol, dexamethasone, does it suppress appropriately? For the medical therapies, often we do look at 24-hour urinary-free cortisol, although, as you probably know, it has its limitations, but sometimes we don't see a normalization in the midnight salivary cortisol, which is sort of one of the downsides of medical therapy. Sometimes we do, but sometimes this daily circadian rhythm is not normalized. But we do have the 24-hour urinary-free cortisol to assess kind of overall response. Is the production of cortisol in the 24-hour period within the normal range? So we see a range of responses shown here. Down here we see a study that actually showed no people had a normal UFC, although this was a short 6-week study, as you can see. But up here we have a study, and some of the other studies show 35 to 40% response. Again, these are all kind of short-term studies. The longest one was 12 months. More recently, there was a larger study that was looking at 62 patients with Cushing's who were treated with Cabergoline. And this study found that actually 40% of people did respond with a normal 24-hour urinary-free cortisol. This figure shows the reduction in urinary-free cortisol at the different doses that were given. People received anywhere from less than 2 milligrams a week to up to greater than 3.5 milligrams a week. As I said, 21 people had a complete response, 7% had sort of a partial response, and about half didn't respond at all. Down here, we show the time frame that was needed to achieve response. So this is looking at the 21 patients who had a complete response, and you can see that some people had a good response in less than 3 months, and some people took greater than 9 months. So there's a range of time that was needed to respond to the medication. So overall, we see that in 30 to 40% of people with Cushing's, there's a good response to Cabergoline with normalization of the urine-free cortisol. The modest response that was seen in some of these small studies could be explained possibly by the low doses that were given. As I mentioned, we can use up to 1 milligram a day for Cushing's. Although some people do respond to these very low doses, just 1 pill a week. Unfortunately, we don't have predictive factors, so we don't have things that we can look at before starting the medicine that might predict if you will respond. And we see a variable time to response, and some people have a lag of a number of months before responding. Over time, a number of people end up stopping the medicine, and the reasons are either intolerance. So at the higher doses we use for Cushing's, there's a higher chance of developing the side effects from Cabergoline, which typically include dizziness and GI, sort of nausea, diarrhea. And also, and we don't know why this happens, but some people have a treatment escape, meaning they respond initially to the medicine, but over time, the cortisol values kind of creep up. So for these two reasons, about 40% of people end up stopping Cabergoline. But overall, it's a safe medicine, it's an oral medicine, and which makes it attractive, and it's a good option for considering if you're thinking about medical therapy for Cushing's. So the second tumor-directed therapy that I'm going to talk about is Pasireotide. So this figure shows the 5 somatostatin receptors that exist in the body. Pasireotide is a medication that binds 4 out of the 5 of these receptors. And it has a substantially higher affinity, about 40 times higher, to this 5th somatostatin receptor, and compared to other medicines in this same family of medicines, lanreotide and octreotide, that are used for growth hormone tumors. But this affinity to the 5th receptor is relevant for Cushing's because this receptor seems to be highly expressed in ACTH tumors. This was the registry trial for Pasireotide approval for the treatment of Cushing's. In this study, 162 adults with Cushing's were treated with a short-acting form of Pasireotide. They received either a lower dose of 600 micrograms twice per day or a higher dose of 900 micrograms. And the endpoint was urinary free cortisol. So I'm showing here the reduction in 24-hour urinary free cortisol that was shown in the study. The patients receiving the 600 microgram dose are shown in red, and the patients receiving the 900 microgram are shown in blue. And after 12 months of treatment, 13% of the people who got the 600 dose achieved a normal UFC, and 25% of the people receiving a 900 microgram dose achieved a normal UFC. The study also looked at clinical outcomes, which of course are very important. They found that overall blood pressure decreased, cholesterol decreased, and weight decreased. Quality of life also improved. For the people who had a visible tumor, so as you know, ACTH tumors tend to be very small. 85% of them are less than a centimeter, or microadenomas, and 40% of the time we can't even see anything on the MRI. Because the tumors are so small, they're below the limit of detection of an MRI, which is about 2 to 3 millimeters. But for the people where there was a visible tumor in MRI, there was an overall average decrease in tumor size by 44%. So there is an effect of this medicine to both lower cortisol and also reduce tumor size. In terms of side effects, GI side effects are common, and that's very typical for this type of medicine. They can include nausea and diarrhea. Often they resolve. But what makes this medicine different from the other somatostatin receptor ligands is that this can unfortunately cause an elevation in glucose levels in a lot of people. So many people become either pre-diabetic or diabetic on this medication, and that's one of the major downsides of this medication. In terms of who's going to respond, there was a much better response in the people with mild Cushing's. So the people who had urinary free cortisol levels that were just above the upper limit of normal, 50% of these people had a good response compared to the people with much, much higher UFCs. And also, you tend to see, if you're going to see a response, you see it early on. So they found that within the first 2 to 3 months, if someone was not going to respond well to the medication, at that time they still did not respond at the end of the study. So this could suggest that a brief trial of the medication might be sufficient in terms of predicting, a long-term response. There's also a long-acting form of this medicine. It's not yet FDA approved. This is obviously attractive because it's a monthly injection rather than a twice-daily injection. But a large study was published just this year of 150 people with Cushing's who got 2 different, either a lower dose or a higher dose of the medication. And they found actually 40% of them were able to achieve a normal UFC. This is higher than the short-acting, as I just mentioned, which I'll discuss down here. But side effects were similar. High glucose and diabetes is seen pretty frequently, some GI side effects. But the reason it looks like there was a higher proportion of people who responded was that the people included in this study had milder Cushing's overall. So they tended to have milder elevations in UFC than the people included in the other study. And that could explain why there was a higher success rate with this medication. So now I'm going to talk about adrenal-directed therapies, medicines that work at the adrenal gland to reduce cortisol synthesis. So Ketoconazole is an antifungal medication. It's been used widely for many years to treat Cushing's because it inhibits cortisol production in the adrenal gland. So this figure shows the different hormones made in the adrenal gland. We have aldosterone, which regulates salt and water balance, cortisol, which you all know well, sex hormones here, precursor DHEAS, which can lead to testosterone and estrogen. And they're all converted through this series of enzyme reactions to the final hormone. So you can see that ketoconazole inhibits these pathways at a number of different steps. Wherever the red arrow is where ketoconazole inhibits the formation of cortisol. So this is both a strength and a weakness of this medication. On the plus side, there is not a buildup of one single hormone. You can imagine if there's sort of a traffic jam here, there's going to be an elevation, a significant elevation of the hormone that occurs right before. And that hormone itself can have effects in the body if that happens. But on the other hand, you can see that there is an inhibition of the androgen pathway. So testosterone can be decreased in men. And unfortunately, that's one of the major downsides of this medication for men. So a number of small studies have been published looking at ketoconazole therapy for Cushing's, but and overall showing a range of responses, anywhere from sort of 25 up to 90% response. Because this medicine is used off-label for the treatment of Cushing's, we don't have any large systematic trials that have been conducted. So in the context of a recent FDA approval of 2 medical therapies of Cushing's in 2012, Pasireotide, which I discussed, and mifepristone, which I'll discuss shortly, and also in the context of a recent FDA warning about the liver toxicities of this medicine, a French multi-center series was published recently looking at 200 patients with Cushing's who are treated with ketoconazole. So this shows the reduction in urine-free cortisol in the people included in the study at a range of doses. People received anywhere from 200 milligrams a day up to 1,200 milligrams a day. And they found that 75% of people had a greater than 50% decrease in their urine-free cortisol. In terms of why people withdrew, why they stopped the medication, lack of efficacy or lack of normalization of the urine-free cortisol was seen in 43%, and side effects were seen in 41%. So what side effects were seen? So in 15% of people, we see that the liver enzymes increased, and in 13% of people, there were GI side effects, nausea, diarrhea. So those were the main sort of adverse effects of this medication. Overall, as I mentioned, 75% of people had a greater than 50% decrease in their urine-free cortisol. About half were completely controlled. So half of the people had a complete normalization of the urine-free cortisol. A quarter had a 50% decrease, and a quarter had basically unchanged values. Interestingly, the average final dose that was shown in this study was 600 milligrams a day. So for those of you who are familiar with the medicine, this is 3 pills daily. It's kind of a small dose overall. It's, we can go up to about 1,200 milligrams a day of ketoconazole if needed. So it raises the question of whether if the dose was increased and titrated up, maybe more people would have responded to the medication. 20% stopped because of intolerance. And looking at the liver enzymes, there was a mild increase in liver enzymes in 13% of people, which is in keeping with what we know about ketoconazole. These are mild changes and they're reversible. So if that happens, we just either go down on the dose or stop the medication and they resolve. More significant increases in liver enzymes were seen in 2.5% of people. Again, there's a concern for a decrease in testosterone levels in men with this medication. Also, you need an acidic stomach to absorb it. So people who take either a proton pump inhibitor or an acid blocker like Zantac, Pepcid, Protonix, that will reduce the absorption of ketoconazole, and that's you need to most likely stop that if you're going to take ketoconazole. Also, there's a black box warning for severe liver injury, and access is restricted in Europe. So looking a little more closely at the liver effects and how safe this is, a recent study looked at this and they found that about 5% of people did develop a liver injury. Although this liver injury can occur at any point in time, it tended to occur within the first 4 weeks of starting the medication. Most people had no symptoms, and the effects tended to be reversible when the medication was stopped. I will say that, I've used Ketoconazole for many years in many patients with Cushing's with a lot of success, and it's generally, I find, an effective medication. I did have this year, actually, 2 of my Cushing's patients develop very severe liver injury with Ketoconazole, and one patient needed to be hospitalized. The other one, it was very, very serious. Fortunately, they both recovered. They're doing great. It was harrowing for all of us, but this did really, show that, despite many years of using the medicine and not seeing this kind of effect, it certainly can occur. And we really need to monitor liver function very closely. That said, I have many patients who are on this medicine for many years and doing really well without any problems. So now I'm going to talk about metirapone. So metirapone is a medicine that's approved in Europe for the treatment of Cushing's. It's not approved in this country, but we are able to obtain it, usually with a little work, a little, authorization letters and forms and calls, but I tend to use it a fair amount, and usually we have success obtaining it. So this medicine, unlike Ketoconazole, remember that inhibited a number of different steps along these pathways. Metirapone blocks just one step, this final conversion of 11-deoxycortisol to cortisol. So again, it's a plus and a minus. On the one hand, we don't see the inhibition of the androgen pathway. So in men, the testosterone will not decrease. That's obviously one of the positive aspects of this medicine. On the other hand, we can't have a buildup of this hormone right here, 11-deoxycortisol, that can sometimes, in some people, lead to a reduction in potassium and an elevation in blood pressure because of buildup of this hormone. It's not seen in all people. Also, there can be sort of a shunting into this androgen testosterone pathway, and in women, sometimes that can cause a worsening acne and hair growth. Again, it's not seen in everyone, but it can occur. So overall, metirapone is a safe and effective therapy. A recent study looked at 195 people with Cushing's. They found that overall 43% achieved a normal 24-hour urinary-free cortisol. Side effects do occur, mostly GI, sort of nausea, diarrhea, dizziness. They tend to occur early on and resolve over time. And it's effective and safe for long-term therapy. And it doesn't have the concern for liver toxicity that Ketoconazole has. So now I'm going to talk about our glucocorticoid receptor blocker, our cortisol receptor blocker, mifepristone. So mifepristone has been around for a long time. It's also known as RU486, known for its progesterone receptor blockade, but it also blocks the cortisol receptor. And it was approved in 2012 for the treatment of high glucose levels due to Cushing's. This was the study that was conducted and submitted to the FDA. So it was 50 people with Cushing's. These were all types of Cushing's, so people with pituitary, adrenal, and ectopic Cushing's were included, and everyone received treatment. Because this medicine blocks the cortisol receptor, it doesn't lower levels. In fact, cortisol levels increase. So we can't measure urine-free cortisol, salivary cortisol, cortisol in the blood. So we can't look at those values because we know that they're going to go up. But we also know that the effect of cortisol is going to be blocked. So for this reason, we can't assess response with our typical endocrine testing. We have to look at clinical outcomes. We look at symptoms, how you're doing, how you're feeling, weight, blood pressure, glucose levels. So that's what this study looked at. Here you can see the glucose level in response to an oral glucose tolerance test. So after drinking a load of glucose, you can see that before people started the medicine, there's an increase to very high glucose levels after drinking this sugary glucose drink. After treatment, the glucose levels decreased. Also, we can see that over time, there was a reduction in weight overall in most patients. So there are some side effects associated with the medication. Some people have nausea and fatigue, and some people withdrew from the study because of the side effects. Some people can develop a low potassium and a high blood pressure, which is something we need to screen for. This tends to occur in people with more severe Cushing's. The reason is that because you're blocking the receptor and the levels go up, there's sort of spillover into other receptors that can mediate these effects. So it's something that we need to watch in people on this medication. There's, of course, a concern for adrenal insufficiency, so low cortisol levels, and especially because we can't measure the level. We can't go by our blood and urine and salivary tests to measure response. So we have to just go by clinical measures, is there any dizziness, nausea, diarrhea? We look at blood pressure, we look at appetite, all the things that we're assessing. But it tended to be uncommon in this study. In women, there can be an effect on the uterus because of the effect to block the progesterone receptor. So some women develop a thickening in the endometrial lining. It's a benign process, it's not malignant, but it does need to be monitored. So now I'm going to discuss a few combination options for people with severe disease. So there's various combinations that can be used, and I'm just going to show a few. For people who have very, very high cortisol levels, often we need to use more than one therapy. So one option is using Cabergoline in combination with Ketoconazole. This is a small study. You can see that most Cushing studies are small. It's a rare disease, as you know, but this was just 12 patients. So these patients were treated with Cabergoline, and they found that 3 of the 12 had a normal 24-hour urinary-free cortisol. The rest of the patients, in the rest of the patients, Ketoconazole was added, and they found that 6 of the 9 patients achieved a normal urinary-free cortisol. So 2/3 of the people were able to normalize their UFC with both Cabergoline and Ketoconazole. So this is a potential combination option. It's attractive in the sense that Cabergoline is a tumor-directed therapy and a Ketoconazole is an adrenal-directed therapy. So we're using kind of different targets to achieve control. Another possibility is using Pasireotide with Cabergoline and Ketoconazole. So this was a small study of 17 people. They were all treated with Pasireotide, and 5 of the 17 had a good response with a normal urinary-free cortisol and Pasireotide alone. In the remaining patients, Cabergoline was added. 4 of these achieved a normal UFC with the 2 medications. And finally, Ketoconazole was added in the remaining patients who did not achieve control with the other 2 medications. And they found that overall there was a very high response rate when using all 3 of these therapies. So it is possible, with very high cortisol levels to achieve normal levels when you combine therapies. So now I'm going to talk about therapy for aggressive tumors. So, as I'm sure you know, ACTH tumors tend to be very small tumors. These are benign tumors. Looking at all types of pituitary tumors, these are one of the smallest ones we see compared to, growth hormone tumors, for example, which tend to be larger overall. So, 85% of these tumors are less than a centimeter, and as I mentioned, almost half of the time we can't even see it on an MRI, it's so small. But there is a subset of people with ACTH tumors who have more invasive and aggressive tumors, so that this can happen. Tumors that are large tumors that can be invasive into the surrounding area, and sometimes even spread distantly to other parts of the body, either to elsewhere in the brain or elsewhere in the body. When that happens, it's called a carcinoma at that point. If there's a metastasis elsewhere in the body, it's no longer called a benign tumor, it's called a carcinoma. So that's very rare, but it can happen. In these situations, we need to kind of turn to more aggressive therapies. So temozolomide is a medicine that's been used to treat these more aggressive pituitary tumors. Temozolomide is a type of chemo, so it's an oral chemo medication. It's approved for the treatment of a type of brain cancer that's called glioblastoma. But it's also been shown to be effective in pituitary tumors that are behaving aggressively. The first reports were published about 12 years ago, just case reports of aggressive tumors that responded. There was a French series of 8 patients published in 2010 of both aggressive tumors and carcinomas, and they found that 3 of the 8 responded to treatment with temozolomide. And more recently, there was a study published in 2015 of 24 patients with aggressive pituitary tumors of all types. So these are prolactin, ACTH, growth hormone, and co-secreting tumors. Interestingly, as I mentioned, these ACTH tumors tend to be very small and benign, but within this subset of more aggressive tumors, we do see actually the prolactin and ACTH tumors are not uncommon in this kind of rare subset. But using temozolomide, there was complete tumor regression in 2 of the carcinomas, the tumors that had spread distantly, and there was partial regression in 7 additional tumors, 4 that were locally aggressive and 4 that had a distant metastasis. So temozolomide is a medicine that really should be considered if there's a more aggressive tumor behavior. So I'm going to talk now about some new therapies that are in clinical trials. The first medicine I'm going to talk about is Osilodrostat, or LCI699. You might remember the figure, this same figure from metyrapone, and it looks exactly the same. So this medicine inhibits the same enzyme that metyrapone inhibits. This is the enzyme involved in the final step in cortisol synthesis. It's a little different than metyrapone because it has, it's a little more potent, it's a little stronger, and also has a longer half-life, meaning that with metyrapone, you tend to need to take it 3 or even 4 times a day. But with this medicine, it can be taken just twice a day because of the longer half-life. So there have actually been 4 trials, and 1 is ongoing, looking at this therapy. The first trial is shown here. It's called LINC1. This is what's called a proof of concept trial, meaning it was just a small number of patients, and it was looking to see how effective this medicine was. Everyone got treatment at escalating doses. You can see that the urine-free cortisol decreased on therapy, and that at the end it was washed out, and the UFC then went up. And actually, 11 of the 12 of these patients achieved a normal 24-hour urinary-free cortisol with this medication. The 12th patient had a 50% decrease in UFC. So the second trial that was done, LINC2, was basically an extension of this trial. So following these same patients over time, they found that there tended to be continued response. So about 80% of people continued to respond well to the medicine. The third trial, LINC3, just completed enrollment, and we don't have the data yet on that study. And finally, there's LINC4, so that's ongoing. This is what's called a randomized placebo-controlled trial. This is a global study with sites all over the world. It's a trial where there's a possibility of getting either active medicine or placebo for 12 weeks. So this is sort of the gold standard type of study design that kind of allows to get sort of the best quality data. It's a little more challenging for patients to know that there's a possibility of placebo for 12 weeks. I would not recommend this study for someone who had very severe or unstable disease. I would not feel comfortable with them having a possibility of 12 weeks of placebo, but it could be appropriate for someone with a milder, more chronic situation. This is an ongoing study, currently enrolling. We're also enrolling at Sloan Kettering for this trial. So now I'm going to talk about Ketoconazole. It's another medication that's being studied, very similar to Ketoconazole. So I'm showing the molecules of these different medications. So Ketoconazole is the molecule is shown here. So it's what we call a racemic mixture, meaning this is one molecule with a mirror image form. So it's two forms of this same molecule. Ketoconazole is just what's called the enantiomer, so it's just the mirror image form, and doesn't contain the other form. So we have some data to suggest that this mirror image form of ketoconazole, levoketoconazole, could be more potent to reduce cortisol synthesis, and may have lower interaction with the liver enzymes, possibly resulting in less potential liver toxicity. There have been 2 trials looking at this medicine. One is the SONIX trial, which has completed enrollment. We don't have the data yet. This is the LOGIX trial, which is ongoing. This is what we call a randomized withdrawal study. So everyone gets treated, and then some people are withdrawn from treatment for 8 weeks. You look at the UFC at that point, and then everyone's put back on treatment. So it's there's a period of possible withdrawal, but then if it's a medicine that works for you and you're responding well, you can continue it long term. The same with the LINC-4 study. So if you're responding to the medicine, you can continue it long term. This study is including all types of Cushing, so pituitary, adrenal, and ectopic, and it's enrolling, and we're also enrolling at Sloan Kettering for this trial. So finally, there's a small study looking at a new drug called ATR 101-301. So remember the picture I showed before of the different pathways and Ketoconazole inhibiting a number of these steps, Multidisciplinary and Osilodrostat inhibiting the final step. So this blocks way up here, it's sort of early on in the pathway where cholesterol is converted into, prior to conversion into kind of an early precursor of cortisol synthesis. So this is a medicine that blocks cortisol production. It's a small study that's enrolling in the US and UK, and it's currently enrolling as well. And we're also participating in this trial. So I want to move a little bit to understanding how ACTH tumors develop and how this can lead potentially to new therapies. So I want to share some exciting ongoing research that's looking into the genetics of Cushing's disease. So until recently, we had very little knowledge about why ACTH tumors develop. A few years ago, 2 studies were published that sequenced all of the active genes, they're called exomes, in a group of ACTH tumors, and discovered that many of them, actually about 35 to 62% of them, had a mutation in a gene that's called the ubiquitin-specific protease 8 gene, USP8 gene. So what is USP8? So it's a gene that regulates the fate and function of various proteins in our cells. It targets a number of proteins for degradation. It's involved specifically in the trafficking of another protein called epidermal growth factor receptor, EGFR. And EGFR is involved in the development of a number of tumor types. And actually, EGFR is involved in ACTH production and has been shown to be expressed in ACTH tumors specifically. So here's the model proposed by the authors of these studies. On the left, you can see a normal ACTH cell, and the right is a cell with one of these USP8 mutations. So you can see that EGFR, which is on the surface of the cell, can either be recycled or it can be degraded. And you can see by the thick arrow here that most of it is degraded and not recycled back up here. So on the right, you can see a cell with this mutation. So the mutation increases the recycling of EGFR back to the membrane. So you can see that more EGFR is up here, and that leads to increase in ACTH production and tumor development. So how could this affect your treatment? So there's actually a medicine called gefitinib that blocks EGFR, and you can see that it would make sense that this medicine might be useful in someone who carries one of these mutations. And actually there's an ongoing trial in China using gefitinib for people with Cushing's who has one of these mutations. So you can see that studying the DNA and the genetics of ACTH tumors could potentially lead to the development of new therapies for Cushing's. Another target that's being looked at is cyclin E. Cyclin E is a protein involved in cell growth and proliferation, and it looks like cyclin E levels are increased in ACTH tumors, but not in other pituitary tumor types and not in the normal pituitary. And there's a medicine, roscovatine, that blocks EGFR. And potentially is a good, it's being studied right now as a potential therapy for Cushing's. There's a study that's ongoing at Cedars-Sinai with Shlomo Melmed's group looking at roscovatine for the treatment of Cushing's. So I want to summarize, I have a few more slides, summarize the medical therapy for Cushing's. So we have only 2 FDA-approved medications for Cushing's. These are Pasireotide and mifepristone. Up until 2012, we actually had no FDA-approved medical therapies. And it's a really exciting time right now for the treatment of Cushing's because, as I showed to you, there's a number of therapies that are being studied for the treatment of Cushing's. We also have Ketoconazole and metirapone that are used widely. Metirapone more commonly in Europe because it's approved there, but as I said, we can obtain it here, and we do have pretty good track record getting it when indicated. For severe disease, we want to consider combination therapy, and for very aggressive tumors, we want to consider tumor-directed therapy and possibly temozolomide. So now I'm going to talk about important considerations for an individualized approach to your treatment. So how do you find the best treatment for you? So it's not easy. There's a lot of options, but it's hard sometimes to find the right option. So you first want to ask, what are your treatment goals? And we may have a lot of these goals, including controlling tumor, controlling cortisol levels, obviously improving quality of life and addressing all the kind of complications associated with Cushing's, weight gain, diabetes, high blood pressure, depression, sleep problems. Of course, we want to address all these issues. But starting with tumor size, you want to ask, would you benefit from a medicine that works directly on your tumor? Do you have a large tumor or a tumor that's only been partially resected, so there's some tumor remaining? In this case, you may want to consider a medicine that works directly at your tumor, like Pasireotide or Cabergoline. If you have a very aggressive tumor or even malignant tumor, a tumor that's spread distantly in your body, in this case, you want to consider temozolomide and possibly more surgery and or radiation therapy. Or do you have a small and what I call well-behaved tumor? So the typical ACTH tumor is a very small tumor. It's sort of indolent, very small growing, in which case you can focus your attention on lowering or blocking cortisol, and you don't need to worry about tumor growth so much. In this case, you could try Ketoconazole or metirapone, which works to lower cortisol levels, or mifepristone, which works to block cortisol effects. So what about how severe your Cushing's is? If your levels are very high and you have very severe Cushing's, you may need combination therapy, as I mentioned. Some people need a medicine that works very rapidly. I didn't discuss it today. Etomidate, because it's given IV and it's used in a very particular situation, a very unstable patient, and it needs to be given in the ICU setting, intensive care unit setting. So that's pretty rare, but it does work to control cortisol very rapidly. And what other conditions need to be addressed or considered? Hypertension, for example, high blood pressure. So often this improves when we treat Cushing's, but there are times it can worsen with some of these therapies. As I mentioned, metirapone can have that buildup of the precursor hormone that can act to sometimes cause an increase in blood pressure and a reduction in potassium levels. So that needs to be monitored. That can also sometimes be seen with mifepristone when there's kind of spillover of the cortisol into a different effect, causing an increase in blood pressure and reduction in potassium levels. What about diabetes? So this tends to, again, improve when we treat Cushing's, but particularly we see a benefit in glucose levels with, for example, mifepristone or Ketoconazole. On the other hand, Pasireotide, as I mentioned, can actually cause diabetes. So we need to consider that and monitor for that. What about acne and hair growth? So this is a common problem for patients with Cushing's, females with Cushing's. This can sometimes worsen with metirapone, as I mentioned, not always, but we need to consider that. And for men with Cushing's, often, the high cortisol levels will reduce testosterone. And in medicine, Ketoconazole can kind of worsen that effect and further lower testosterone. So that's sort of, less attractive option for men. And we also need stomach acid for Ketoconazole. What about fertility? So fertility comes up a lot. I have a number of patients with Cushing's who, are interested in and desire fertility. We know that Cushing's is much more common in women, and particularly young women, so it's an issue that we discuss a lot. If there's persistent Cushing's, sort of the guidelines recommend that we recommend bilateral adrenalectomy. So we recommend that the adrenals be removed, and then we treat the primary adrenal insufficiency, and then allow for fertility after that. Because unfortunately we have no medical therapies that are approved for the treatment of Cushing's in pregnancy. However, we do have a number of case reports of successful pregnancies in women with Cushing's who are taking metirapone. So if there is a pregnancy in a woman who has active Cushing's, metirapone is the favored therapy to try. We also want to consider availability and cost of the medication, what prior treatments have been tried, what has been successful, what side effects do you experience, do you have a preference for oral or injection? Of course, we all prefer oral, but is injection tolerable? Number of daily doses for the medicines that need to be taken multiple times per day. Is that, is that going to be an issue to adhere to that, or, less attractive option? And also you want to look at what other medications you're taking. So some of these therapies have a number of drug-drug interactions, particularly mifepristone and ketoconazole. So you want to be aware of that and check your medication list to make sure there isn't a contraindication. So finally, do you want to consider a clinical trial? Is there one that you'd be eligible for and that could benefit from? Are there sites close to you? And do you have time to commit to this trial? So I generally say, overall the potential upside of participating in a trial is that you could have access to a medicine that potentially could be very effective, attractive medicine for you that's not otherwise available. And if it's a good medicine, typically you're able to continue it long term, even before it becomes approved. On the other hand, there's an inconvenience of being in a trial. It's more work. You have to adhere to the protocol, come to the visits at certain, usually more frequent visits, more frequent testing, a lot of urine collections, which I know are cumbersome. So you have to kind of weigh the pluses and minuses. And also, of course, whether this is an appropriate, any of these offer a medicine that could be appropriate and safe for you. And of course, you need to consult with your endocrinologist about that. I encourage you to look at this site, clinicaltrials.gov. You can go on there and search Cushing's and see all the available trials that are ongoing for Cushing's. So the most important considerations, and these are things I know that you all know already, but you want treatment with an experienced neuroendocrinologist. You want to be a typical patient, not an interesting case. So this is very important. In my clinic, I see sometimes maybe 5 or 6 Cushing's patients a day, and it's very routine for us, and that's the situation you want. You want someone who has a lot of experience treating this disease and can offer you the care that you need. Ideally, it's great to get care in a multidisciplinary center that has expertise in the various disciplines that you might need, including endocrine, surgical, and radiation therapy. You want a team that communicates regularly. We have a multidisciplinary clinic at Sloan Kettering where I see patients alongside my colleagues, and so it really facilitates communication, and it's also great for patients. They can come with one visit and see us all. You want a team that has regular conferences. So we have a Pituitary tumor board that meets every other week with our larger group of a neuroradiologist, neuro-oncologist, radiation oncologist, a surgeon. So we all gather to discuss the patients we're treating. We have a lot of challenging cases, and it's really important to discuss the management plan with the whole team. If you need more advanced care, obviously it's important to be able to have access to that. If you have very severe Cushing's, or if you have an aggressive or malignant tumor that needs more aggressive therapy. And it's also important to have access to clinical trials, even if you don't want to participate, or you're not eligible, or you're not interested, or you don't need it. Just knowing what's out there, what research is ongoing, what could be a potential option for you if needed. And finally, and you know this already, you want a team of doctors that listens and advocates for you and that you feel comfortable communicating with. Cushing's is a really challenging disease, as you all know. I've seen a lot of people suffer, sometimes for many years. And you really want a doctor and a team that's going to remain determined to find the right treatment for you. So I'm going to conclude by acknowledging my team at Sloan Kettering. We work alongside each other to deliver personalized and integrated care for our patients. Two of the main goals of our center are excellence in patient care and engaging in clinical research that aims to improve the care and outcomes for our pituitary patients. So I want to thank you today for your time. I hope this was useful for you, and I look forward to hearing your questions.
Thank you so much. That was excellent. I really like what you said about being the typical patient, not the interesting case. It is a very good message and something that everybody should strive to be more typical and go to doctors who are more familiar and can help in a better environment with the team.
Mm-hmm.
So, a few questions. First one, and we're going to try this chat, I'll send it to you, is asking about information on cyclical Cushings and pseudo-Cushings, how to diagnose and treat.
Okay, so that's an excellent question. So the diagnosis of Cushing's is a whole separate talk, and I'd be happy to talk about that. We can briefly touch on it today, but it's obviously one of the most challenging things in endocrinology and in Cushing's is first just to make the diagnosis. This can be really hard to differentiate what we call pseudo-Cushing's from true Cushing's. Pseudo-Cushing's means that there's an elevation in cortisol from something else. So the body is responding to a stressor by raising cortisol levels. The stressor could be obesity, it could be depression, it could be alcoholism. So there's a number of things that raise cortisol levels. And trying to differentiate if it's pseudo-Cushing's, meaning the cortisol is elevated, but not from a tumor, not from a pituitary or adrenal or ectopic tumor. And similarly, cyclical Cushing's is another challenging very challenging situation. So this is when there's intermittent fluctuation of hormone secretion from the tumor. So this is different from just the variation in results that we see. For example, with the 24-hour urinary-free cortisol, we know that there's a lot of variation from one time to the next in terms of the values we see, and this has been shown in studies. There's a wide range of results. We don't really know why that happens, but it can be a little frustrating. But we do know that it's very typical to see very high levels sometimes. Sometimes you can have a normal UFC and still have Cushing's. And that's why when we're making the diagnosis, what I talk about with my patients is looking at the overall picture. We want to put the whole picture together. We want to look at all the tests we're doing, the urine-free cortisol, the salivary cortisol, the DEX suppression. We want to look at the symptoms, the changes in the body, what's happening, and you can't rely on one single test. So you can't, sometimes you could have a positive, an elevated midnight salivary cortisol because those are very sensitive. They can go up even just from, stressor or time change, but we can't rely on a single test. We really have to kind of put the picture together. It can be very frustrating for patients because it means repeating the test a number of times sometimes over time, and I know collecting your urine for 24 hours and keeping it in the fridge is not a pleasant experience, and it's very cumbersome. But we do, and it's frustrating sometimes for patients when we talk about this because they want a diagnosis, understandably, and that it's hard to understand sometimes why we need to repeat the test so many times. If the values are very elevated, it makes it easier because we know it's Cushing's. But if it's a milder situation or a cyclical situation, we do need to repeat over time. And generally, Cushing's will present itself. The situation will progress, the symptoms, the tests will progress over time. And we want to sort of catch, with cyclical Cushing's, we want to catch the values that are high, and that can help with making the diagnosis. So for cyclical Cushing's, midnight salivary cortisol collections are very helpful because obviously they're easier to do than the urine. So you can kind of repeat them over time. You can do them every few nights for a week. You can do it weekly for a month. You can do it over months. And because it's so easy to do, you want to catch it particularly when you're having symptoms, and over time. If it truly is cyclical Cushing's and it's true Cushing's, not pseudo Cushing's, you will be able to make the diagnosis. Back to pseudo Cushing's, again, typically the values overall are less severely elevated. Often in pseudo Cushing's, we see elevations in the urine-free cortisol, but it responds appropriately to suppression. So you see a UFC that might be a little high, but the cortisol responds to dexamethasone. So we see a normal suppression with dexamethasone, but a slightly high UFC. That's sort of a typical situation. There are other more advanced endocrine testing that we can do to differentiate pseudo-Cushings from true Cushings. One is called the dexamethasone-suppressed CRH test. So basically this is a low-dose 2-day dexamethasone suppression test. So you take dex every 6 hours, 8 times. Then you come into the office after your final dose and you're given CRH. The idea is that after suppressing your cortisol with dexamethasone over those 2 days, someone without Cushing is not going to respond to the CRH, which stimulates cortisol. You're going to be so suppressed that giving CRH is not going to stimulate the cortisol. With true Cushing's, we do see that the cortisol can go up. So even after it's been suppressed with dexamethasone, stimulating it with cortisol stimulating it with CRH will result with an increase in cortisol. So that's one test that can be used to try and differentiate pseudo-Cushing's from true Cushing's. Obviously, this is a much longer conversation. There's a whole other talk about both diagnosing and localizing Cushing's, and it is a very challenging situation for patients, and it's also, you need patience sometimes.
Excellent, thank you. Next question, are they working on getting metirapone approved in the United States?
So that's a good question. Not to my knowledge. I think this had been studied in the past, had been looked at, and then my understanding was it was dropped. But we do, as I mentioned, we have LCI699 or Osilodrostat, which works on the same enzyme that metirapone works at to inhibit cortisol. So it's a very similar type of medicine, possibly slightly more attractive if it gets approved. Of course, that's an if, because it has a longer half-life and it might be slightly stronger. The problem with Cushing's is that, it's a rare disease, so we need to have interest in it. So there's not, we need to have sponsors and investigators that are interested in and motivated to get these medicines approved. So to my knowledge, no, but as I said, metirapone is available in this country technically for diagnostic purposes, but we can get it. So we have pretty good, we are able to get it, and I often do that for my patients with a little effort to do it, but it is possible.
Okay, thank you. On the clinical trials, I know you touched on that a little bit in clinicaltrials.gov. Can patients contact your team to get involved in the clinical trials, or is it better for them to go through clinicaltrials.gov?
Yeah, they can certainly contact us for more information or to see if they're eligible. On clinicaltrials.gov, you'll see the sites that are open. So you want to have a site that's, relatively close to you. I mean, I do have patients who travel in from farther distance to participate in these trials, but you want to be aware that there are some frequent visits, and the visits and the testing needs to all be done here. So you can't do outside labs. It has to all be sent to a central lab. But you certainly could contact us and just look online and find out about where sites that are close to you, and talk to your endocrinologist about available trials that you could be eligible for. But I'd be happy to talk with anyone about these trials if you think you might be interested in eligible.
Okay, great, thank you. This next one's a little long. This is the one I emailed you. So this patient is in their second time of having Cushing's with a pituitary tumor, and the first time she gained 61 pounds. This time, she's lost 36 pounds and have experienced a much better quality of life while sick. I'm working with an endocrinologist, an MD who practices alternative medicine and who has a master's in nutritional biochemistry, and an iridologist. Developed Cushing's in October 2016. At that time, I weighed 180 pounds. By December, I weighed 203 with all the symptoms of Cushing's. I went to see the alternative MD in April 2017, who did a live blood cell test that resulted in bad bacteria and fungus. The iridologist says I have a lot of toxins in my body. I have chronic loose stools that look furry with bubbles that come from it. I have been put on a strict no-starch diet and plan to modify the keto diet to change my metabolic system over to get energy from burning fat, not sugars. My theory is people with Cushing's can't properly digest starches, but it doesn't show up until the starches turn to sugar and we become diabetic. I can't be so unique that this only works for me. Can a study be done with Cushing's patients using my diet formula? This diet cannot be found anywhere because I developed it through trial and error. My heart breaks for all those suffering with this disease when I know from the second time my life has been so much better. I want to make life better for those suffering. So what do you think about the starches, and does diet help?
Okay, so so thank you for sharing your experience. So it's helpful to hear about what people go through, because it is, as I mentioned, it's really a chronic disease that can recur often. So so I can't comment on the specific issue of the bacteria and the fungus without knowing more, and I also don't know very much about iridology. I will confess, but what you bring up actually raises a few important points. One is that cortisol, as we know, is a stress hormone. It's a fight or flight hormone. So when your body, our body makes more when we're in a fight or flight situation, meaning we're, at other, times our species was, fighting or running from a large animal. We need, and what cortisol does to deal with this situation is it tries to elevate the sugar, the glucose in the blood to have fuel for this situation. So it does this through a lot of different ways. It reduces the glucose production from the liver, high cortisol levels. It reduces glucose uptake into the tissues. It reduces insulin secretion from the pancreas, and it also increases our resistance to insulin. So the body, insulin is less effective. So these are some of the ways that cortisol works to raise glucose or sugar levels in the blood, and that's why people with Cushing's are at high risk for developing diabetes. So diet is very important in this situation. And important in general for health, but I would say it does make sense to try and avoid concentrated sweets and a lot of carbohydrates. You want to focus on a diet that has high fiber, a lot of vegetables, some fruits, some lean proteins, and whole foods, not processed foods. So there can be, often diabetes can be quite severe with Cushing's, and of course you need medical therapy, but diet plays a very important role in terms of, one, controlling glucose abnormalities and also controlling weight. So this brings up the second issue, which is that with recurrence, we often see a much milder situation. Unfortunately, as many of you probably know, the initial diagnosis can take years sometimes because it's a rare disease. People don't think of it. A lot of the symptoms can overlap with very common things that other people have, like weight gain, depression, diabetes. So unfortunately, and I see this a lot, that by the time the Cushing's patient gets to me, it's been a number of years. I always ask my patient when their symptoms first started, because that's sort of a helpful marker in terms of how long there's been exposure to this high level of cortisol, and it is sadly often many years. But when a recurrence happens, if a recurrence happens, we catch it much sooner. So I tell my patients that they'll be the first to know if it happens. They know because the same Cushing's come back. So fortunately, this means we can catch it earlier, we can treat it earlier. So we tend to see, and as you mentioned in this situation, there's less weight gain and less severe symptoms, which could be related to, in part, the strict diet that you're following, but also the fact that we can catch things in a much milder state and hopefully treat it sooner. So that brings me to my final point, which is that I hope you're getting treatment of the Cushing's in addition to the diet you're following, and it sounds like that's having good results for you, but I want to urge you to make sure you're getting appropriate treatment, whether it's additional surgery or medical therapy to normalize your cortisol levels if they're high, because we know that continuing with untreated Cushing's really has so many adverse effects on the body, and also will shorten your lifespan. So you do need additional treatment for the Cushing's.
Thank you. Is it possible to have Cushing's without a textbook Cushingoid look? Are there atypical presentations?
So it's definitely possible. So we see a range of changes in the body that occur, and I'm always struck by the fact that the testing we do, the endocrine testing, the urine-free cortisol, for example, doesn't correlate with the physical changes we see in the body. often. Sometimes it does, sometimes it doesn't. So I've seen people with very mildly elevated urine-free cortisol levels who look very Cushing-like. On the other hand, you can see very markedly elevated cortisol levels in people who really don't look Cushing-like at all. So there's a number of factors that happen. One is, as I mentioned, lifestyle. So some people, I've seen people with Cushing's who really don't have much weight gain and don't look Cushing-like because of serious hard work with diet and exercise, and it's very hard, but sometimes that can kind of lessen the effects on the body. Also, sort of how long it's been going on has a big role. So if there's sort of a rapid onset or it's an early diagnosis, there hasn't been enough time for the changes in the body to take place. Whereas some people who've had Cushing's for a long time, there's more, the body doesn't change immediately. It takes months and years to have the effects. So if it's been going on for a long time, you can have more Cushing's effects. But there's also something which I think we don't understand, which is that how the cortisol affects the tissues. So we have these other measures. We measure cortisol in the blood, the urine, the saliva, but we don't measure the effect in the tissue. And there's definitely differences in how sensitive people are to its effects, probably differences in the receptor, how it's metabolized in the tissue, that some people do seem to be more sensitive to the effects and have more dramatic Cushing's changes, and some people are less sensitive to those effects.
Great, thank you. It looks like that concludes the questions. Thank you so much, Dr. Geer, for taking time out of your busy schedule. We appreciate this very informative and valuable information that we've received today. This concludes today's webinar presentation. We appreciate you all taking the time to join us and for your excellent questions. We did answer all the questions. We don't need to do any by email. If you missed any part of this webinar, or if you'd like to share it with family members or friends, it'll be available on our website, pituitary.org, hopefully by the end of the day. We need to do some editing. After we end this, there'll be a brief survey. Please fill it out to help us provide you with the information you need. Thank you for joining us, and everybody enjoy the rest of your day. And Dr. Geer, thank you again so much.
Okay, thank you.